Okay, next on the agenda is what might be considered the main event for the morning, I suppose, is the House File 4247, which is,
So many burning.
House File 4247, which is the minibus scope and licensing bill. And today, all we're going to do with the bill is have a walkthrough, and we're going to take testimony on the bill, and then we're going to have markup tomorrow. So we're not doing any amendments today, although amendments to the bill have been posted. So in your packets, you have the bill, you have the spreadsheet for the bill. This is all special revenue funds. And so we are not going to actually move the bill this morning, I guess, or should we move the bill? We should maybe move it, bring it before the committee. And then lay it over. Okay, maybe I think I kind of need to move it to bring it before the committee. So I'm going to move House File 4247 to bring it before the committee, and the motion will be to send it to Ways and Means. So when we vote this out tomorrow, it'll go to Ways and Means. So with that, I'm going to ask Ms. Sunderman to give us a high-level, well, let me first actually move the DE. So that's a good reason to have moved the bill in the first place. Okay, so we should adopt the DE so that we can then walk through it. So then I'm going to move the DE3 amendment to House File 4247, which is the omnibus, the minibus bill, I should say. So all in favor of adoption of DE3, please say aye. Aye. Opposed? Motion prevails, and the DE3 is adopted. Okay, now that we got all that out of the way, I think we can go to Ms. Sunderman to do a walkthrough of the bill.
All right, Madam Chair and members, as Chair Liebling said, I'll be doing a high-level walkthrough of the DE3 amendment. So Article 1 provides for registration of transfer care specialists by the Commissioner of Health and authorizes transfer care specialists who are registered with the Commissioner to remove and transport dead human bodies from the place of death to a licensed funeral establishment. And this was from House File 2509, the first engrossment. Moving to Article 2. This was from House File 3741 as amended in committee. This article establishes behavior analyst licensure to practice applied behavior analysis. It establishes the Behavior Analyst Advisory Council, specifies fees, and appropriates money later on in Article 9 for the implementation. Moving to Article 3, the Board of Veterinary Medicine. This article establishes licensure for veterinary technicians from House File 1228 and makes related changes. And then it also modifies institutional or faculty licensure at the University of Minnesota. That was from House File 1817 as amended, and that's for any person who is not eligible for a regular veterinary license seeking to practice veterinary medicine while employed at the University of Minnesota. Article 4 is the Board of Dentistry. This article allows specialty dentists who hold general dental licenses to practice general dentistry outside of their designated specialty area. That is from House File 3612. And it also modifies a requirement for dental assistant licensure by credential from House File 2111. That's just changing an or to an, or an and to an or. Article 5. Physician assistant practice. This is a repealer. This is House File 3494. It repeals Section 147A.09, Subdivision 5, which contains collaborative practice agreement requirements for physician assistants to provide ongoing psychiatric treatment. Under current law, a physician assistant has to have an additional practice agreement with the licensed physician in order to provide ongoing psychiatric treatment. And it specifies what that additional agreement must include. Article 6 is the Board of Social Work. This is from House File 3626 as amended in committee. This article reorganizes and modifies sections of statute governing the Board of Social Work provisional licensure. modifies requirements related to provisional licensure eligibility, disciplinary action, and supervision. And it also includes a revisor instruction to renumber the listed social work provisional license sections of statute into Chapter 148E with the rest of the social work statutes. Article 7, the Board of Marriage and Family Therapy. This article was from the original House File 4247. It establishes guest licensure for the Board of Marriage and Family Therapy for eligible non-residents who wish to practice temporarily in Minnesota without being licensed, and it also establishes fees. Article 8, this is the Board of Pharmacy article. This article adds Board of Pharmacy application and fee requirements for relocation and change of ownership of licensed entities, and specifies that licenses and registrations are not transferable. These provisions are from House File 4099. The article also modifies opiate manufacturer, wholesaler, and third-party logistics provider reporting requirements, and this is from House File 4098. And finally, Article 9 is the appropriations article, and it includes appropriations from the State Government Special Revenue Fund to the Commissioner of Health, Board of Psychology, Board of Veterinary Medicine, Board of Dentistry, Board of Social Work, Board of Marriage and Family Therapy to implement the provisions in the rest of the bill. And that is the bill.
All right, thank you, Ms. Sunderman. So a little smaller than what we usually do in this committee, right? And I guess I would just add that there's really nothing in here that didn't come through committee, and the amendments are all amendments that were done here in committee. So some of the blanks got filled in from, some of the blank appropriations got filled in from fiscal notes and so on. So we have some testifiers who have signed up, and so we can take testimony on the bill. And so I have on the list Sue Abderholden. Welcome to the committee. Please go ahead and give your name and go ahead with your testimony.
Thank you, Madam Chair. Members, Sue Abderholden, Executive Director of NAMI Minnesota. And we have serious concerns with the bill as written. We fully understand the dire need to increase access to mental health care and to build our workforce, but we must take great care not to compromise on the quality of care. While PAs typically complete around 2,000 hours of postgraduate patient care, they only take 1 2-semester credit course in psychiatry and a 4 to 6 week rotation in psychiatry. This is very different than APRNs, who are required to choose one of 4 roles and then choose one population focus, one of which is psychiatric and mental health care. APRNs who don't specialize in psychiatry are directed not to treat people with serious mental illnesses. The U of M Psych APRN program is a doctoral level program, and most of the 81 academic credits are on mental health, and 960 of their 1,000 hours are psychiatric-specific patient care. Other mental health professionals, such as social workers, are required to have 4,000 hours. One class and one rotation does not qualify you to diagnose and treat people with serious mental illness, such as schizophrenia, bipolar disorder, major depression, and other diagnoses that involve psychosis. Schizophrenia is one of the most disabling conditions in the world. PAs are simply not qualified to diagnose or develop a treatment plan for this serious illness or others. We have not found a hospital provider who is confused by the current statute, and you can easily clarify what serious mental illnesses are by listing them. 2013 legislative report found that PAs are underqualified to serve people with serious mental illnesses. Our state is not more restrictive than other states. In fact, the National PA Organization found only 3 states are rated less restrictive than Minnesota, and they found over 20 states being rated more restrictive. It's been said to our members that PAs are clear in their scope of practice and would refer people with these illnesses on to psychiatrists, but then why change the law? There is no reason to repeal this section of the statute. We are open to allowing PAs to specialize, provided they have additional training and take their national tests in psychiatry as recommended by their national organization. We are open to clarifying the law. We are not open to repealing the law. Before you vote, I ask that you pause and remember that the very people that PAs want to treat don't want this law repealed. The people who are actually trained to diagnose and treat people with serious mental illnesses, psychiatrists, psychologists, other mental health professionals, don't want this law repealed. Thank you.
Thank you. So next I have, let's see, where's my list? Oh, there we go. I have Tom Lehman. Oh. Welcome to the committee.
Thank you, Madam Chair. It's an interesting day. I think I'm the only person here in support of your bill.
That's really sad.
It is, and I appreciate being here. Madam Chair, members, my name's Tom Lehman. I'm here on behalf of the Minnesota Academy of Physician Assistants. Appreciate this opportunity to comment on the DE amendment. Unlike the previous testifier, I'll be speaking in support of the bill and in support of patients who need mental health services. We want to thank you, Chair Liebling, for Article 5 in the bill, which includes the provisions of Representative Bonner's bill to expand access to mental health services. As you heard in testimony on her bill and continue to hear from advocates, from hospitals, from clinics, from law enforcement agencies, from schools and families, the demand for mental health services is increasing at the same time we're experiencing severe shortages of clinicians who can diagnose mental illness, prescribe medications, and monitor the reactions to those medications. We've heard statements that the mental health system is in crisis because of this shortage. The previous testifier said this multiple times this session. Yesterday in Representative Fisher's committee, she submitted written testimony that, quote, everyone at NAMI, Minnesota has heard from parents and children with mental illnesses trying desperately to get their child the services they need. She's correct. We need more mental health providers of all types and of all licensures. Article 5 helps address the shortage of mental health clinicians. I remind you that the Board of Medical Practice strongly supports this provision because the concerns raised by the opponents have no merit. Madam Chair, budget realities mean you'll not be given a budget target this year that will allow you to make needed investments in our healthcare system, including mental health. But Article 5 of your bill will make a meaningful difference for patients who are waiting to get the mental health care they need and the hospitals where these patients are now being warehoused in emergency departments. Thank you, Madam Chair, for including this important provision in your bill, and I encourage members of the committee to continue to support it. Thank you.
All right, thank you, Mr. Lehman. And I'm sure there are other people here who are supporting the bill. They're just not coming up to testify.
They're not a shock.
Really? I think he's the only one. No.
So, okay, so we can take some questions, I guess. I mean, if there are specific questions of the testifiers, I think we could do that. Otherwise, you know, we're not really, I guess this is the time if we're going to do that. Representative Bierman?
Yeah, I wondered if Ms. Abderholden could come back down.
And also, just since we're talking about language that is being repealed in the bill, I don't know, Ms. Sunderman, is the language actually here someplace so that we could be looking at it?
Madam Chair, members, no, it isn't. When it's posted, I believe when the first engrossment is posted on the reviser's website, the repealer language will be there.
Okay. All right, so members, if you want to look at the language, which I think might be important here, it's section 147A.09 subdivision 5, if you're pulling it up on your computers or, so it's a short paragraph.
Can you say that
One more time, please.
Yeah, it's in the bill. The repealer is section 147A.09 subdivision 5.
Thank you, Madam Chair. I just wanted, Ms. Abderholden, I just wanted to ask a question on the, first off, Mr. Lehman made the comment about the need for mental health treatment, and obviously that's known by all of us. And there's just a very wide continuum of care in mental health. And I think what we're talking about or concerned about are the extreme cases of psychiatric care that are further beyond perhaps the training of the PAs, in your opinion. And I just am wanting to understand that the current practice contains collaborative care practice, which would be a PA, maybe a psychiatric medical doctor, and an administrator to help coordinate that. So I'm just wondering, with this change in law, whether the PA becomes strictly in charge of this patient and it's not collaborative care anymore, or if they would seek out further treatment with a professional who has that more advanced practice that you described. And I just want your understanding of that.
Ms. Abderholden.
Thank you, Madam Chair. Representative Bierman. In one of the kind of online forms for a practice agreement, antipsychotics were not even listed as something you would check off to be able to even prescribe. And I just truly worry because when we've heard the testimony from PAs, it's like, we're able to do this. And I think there has to be some knowledge of, what you don't know. And diagnosing schizophrenia is actually very difficult, as is bipolar disorder. If you prescribe the wrong medication for bipolar disorder, thinking it's depression, you can send someone into mania. There's just a lot there. And frankly, we just don't want to risk that. These are complicated mental illnesses, and they should only be diagnosed on the initial treatment plan. Remember, under the current statute, you can do ongoing. So once someone is stabilized with schizophrenia, yes, use the PAs to make sure they continue with their medication and can get prescriptions. But that initial diagnosis and that initial treatment plan, which often takes many different medications before you find the right one, should not be done by a PA, even with consultation.
Thank you.
Representative Bierman.
Thank you, Madam Chair. Thank you for that clarification and your understanding. And I do think that it's really important that everybody in the medical field nowadays is practicing up to their scope and making sure that we're utilizing the abilities of all professionals at all levels. And you commented on the APRNs may be better qualified in this capacity. And so I'm just trying to make sure that if there's a need for a higher professionalism, that it's still there in the bill. And just to understand that how important that is, practicing up to your scope. And if PAs can do mental health treatment to a certain level, we want to keep that happening. So appreciate your comments. Thank you.
Madam Chair?
Oh, well, we have a couple other questions on the list here.
I would like to hear a response.
Oh,
if I may.
response, okay. Ms. Abderholden.
Madam Chair, Representative Bierman, on the National PA website, they talk about how PAs can specialize in mental health care, taking, for example, a year-long training program like we have at Regents Hospital, taking the national test. If they did that, we would be more comfortable with them actually specializing in psychiatry.
Thank you. Thank you, Madam Chair.
Thank you. Okay, Representative Nadal?
Thank you, Madam Chair, and thank you, Ms. Aberholden. So, prohibiting subdivision 5, eliminating subdivision 5 as a prohibition of service, does it make you feel any better with subdivision 3 in that statute remaining in place that requires a PA to have that practice agreement at the practice level that describes the practice and having that relationship with the doctor? That's remaining in statute. So that doesn't make you, can you talk about why that doesn't make you feel any better?
Ms. Abderholden.
Madam Chair, Representative Doe, it doesn't make me feel any better because I just don't think that's the scope of practice that they should be engaged in, even if they're working, with a physician. Again, PAs can actually have their own practice. They don't have to have a doctor on site. And when we're talking about serious mental illnesses, that really does make me nervous. These are the people that I hear from every day. At NAMI, nearly 100% of our board, staff, volunteers either live with a mental illness, have a family member, and they were all like, no, we don't think they have the experience or the training to do this. And sometimes you don't actually know, when you call and make an appointment that it's a PA. And so I think, it's just really important that if you're going to diagnose and treat, that you have more than one class and more than one 4 to 6 week rotation.
Representative Nadeau.
And just one follow-up. And I mean, and I'm reading this, and it says the physician assistant shall have a practice agreement. So they can have their own clinic. I get all this, but they shall have a practice agreement. So they can't practice without an agreement. Is that not true?
Yeah, and I'll respond to that. Yeah, that is absolutely the case, Representative Nadeau.
Thank you.
Yeah. New Brindley, Representative New Brindley.
Thank you, Madam Chair. And clearly, we're all thinking along the same lines. And so thank you for being here, Ms. Abderholden. So my question is, they have a practice agreement in place. However, even with the practice agreement in place, they're able to have their own freestanding practice without a physician physically on the premises? So they don't have direct supervision or necessarily direct consultation with the physician?
Yeah, and I think maybe we should get Mr. Lehman down here because he represents the PAs. I don't know if Ms. Abderholden is sort of the expert on all things PA. If you're asking kind of a general question, Representative New Brindley?
Thank you, Madam Chair. I'd be happy to hear from the perspective from both of them.
Yeah, I mean, it's a matter of, or maybe even Ms. Sunderman, I mean, because it's kind of, you're asking a question about what does the law allow? But, I mean, Ms. Abderholden, go ahead.
Madam Chair, Representative, on their website, they have a Q&A, and it says on there, can you open up your own practice and not have a physician there? You still have to have the collaborative agreement, and it says yes, and it tells them how to do it. So I assume that then that's what they can do.
Representative New Brindley?
Thank you, Madam Chair. I don't know if Mr. Lehman wants to
Mr. Lehman.
contradict that at all, or?
Well,
Yeah, Mr. Lehman.
again, Tom Lehman on behalf of the Minnesota Academy of Physician Assistants. Madam Chair, Representative New Brindley, PAs do not have independent practice. PAs cannot open their own clinic. PAs cannot start a mental health center and run it themselves. PAs must have a collaborative agreement with a licensed physician. The PAs that practice in Minnesota all have that. Some practice, whether it's in psychiatry, orthopedics, neurology, a host of specialties, depending on the clinic or the practice site, a physician may be there, may not be there. This initially was brought to us, this issue was brought to us by Hennepin Health, who had a PA in charge of a mental health clinic in South Minneapolis and had the practice agreement with the psychiatrist, but their lawyers, well, apparently, I don't know if it's their lawyers, but Hennepin Health determined that they weren't comfortable having a PA running a clinic, even though they're licensed to provide these services by the Board of Medical Practice. And so they were looking at shutting down this clinic and removing access to mental health services in this area of South Minneapolis. They subsequently found a workaround. And the PA was able to continue running that clinic. The comment we have in response to that is, if a law requires a workaround to allow licensed clinicians to provide desperately needed care, that suggests that the law there may be some issues with that law.
All right, Representative New Brindley?
Thank you, Madam Chair. So you said that they are currently licensed to provide these services. So presumably, in that clinical setting, they were exclusively providing the ongoing psychiatric treatment and not the initial diagnosis and care plan?
No. Mr. Lehman?
Madam Chair, thank you. Representative Brittany. PAs are licensed to diagnose, prescribe medications, and monitor ongoing compliance or ongoing reactions to that medication. A patient may enter a clinic, and this happens every day, all across the state, and they see a PA. PAs provide over 10 million patient visits a year. This is, there's a lot of PAs and they're providing good care across the state. But a patient can enter a clinic, mental health clinic, or a general practice clinic, and the PA can diagnose that this person has a mental illness. That happens daily. The majority actually of mental health diagnoses are done in the family practice setting, and the majority of medications dealing with mental illness are not prescribed by psychiatrists, they're prescribed by family practice and other, internal medicine and other folks. Now, in the case of a patient that is severely mentally ill, Sue Abderholden referenced this, it's up to the PA in consultation with their, the practice agreement that they have with their physician to determine, is this something I can handle or is this something I need to refer on? Just to remind folks, this happens every day across healthcare. Whether you're a PA, an APRN, a physician, a patient may present and that clinician may say, this is beyond my abilities and I need to refer to a specialist or a subspecialist. But in answer to your question, a PA can diagnose the initial mental illness, can prescribe medications, and can monitor that.
Okay.
Thank you,
One
Madam.
more, Representative.
Thank you, Madam Chair, and thank you for that. I expressed concern with this initially, and I continue to have concern with this because I do believe that we're trying to equate a PA with psychiatric training that they don't necessarily have. And we were getting to this point in the initial hearing as well. And while my concern is that while we are suggesting that they can and should seek collaboration with psychiatrists and other mental health professionals, it will no longer be required under the law. And that is concerning to me, that this removes that protection, that they're able to provide that ongoing psychiatric care. But now, even without the advanced education and training, they are allowed to provide the initial diagnosis and treatment plan. I do think that that's concerning. And I also have a real concern. I am so aware of the mental health crisis that we have. But I become very concerned when our solution to that is to decrease the training and the education requirements of providers. And to be clear, I'm a huge fan of PAs. That's actually my choice. I usually choose either a PA or an APRN for my own health care because I just like seeing them better. I like the care I receive from them. But it does feel like in this instance that perhaps we are eliminating some really important requirements that would currently exist. Thank you, Madam Chair.
Thank you, Representative Brindley. And I'd like to just make a comment as well. So, the issue expressed here, the issue between, access and competency is one that we face all across these licensing and scope bills. That's kind of our, the quintessential problem that we face. How do we balance these? I'd like everyone to look carefully at what is being repealed here. The word diagnosis does not appear. I've been really wondering where everybody's getting this from, because PAs right now can diagnose, and if this is repealed, they will still be able to diagnose. This does not stop any diagnosis right now being in the law. I think Representative Nadeau was really putting his finger on it. We have to, whatever issues there might be, however much we might like to see more guardrails around this or that, what we're doing here doesn't touch any of that. This just operates as an additional, to me, it's almost like a redundancy. It's just saying again, and we really mean it, with regard to psychiatric issues. There's nowhere here that it says a PA may not diagnose. A PA may diagnose, as Mr. Lehman was saying. So while I appreciate members' concerns, and my understanding of how PAs operate is that, just like physicians, whose scope is really not laid out in statute. I mean, I like to use my husband. I probably did in the regular, in the hearing on the bill. My husband is an internist, trained internist. He does not do surgery. His license says he could do surgery. He doesn't do surgery because he knows that's not his scope. He's not trained to do surgery. This happens all across physician practice. And PAs who function, who are under the Board of Medical Practice, who are medically trained like physicians and who operate with collaborative agreement always, have the same kind of thing. It isn't spelled out in their practice statute. Now, we could argue it should be. We could argue that maybe we don't like what their scope is or we want it, but this bill isn't doing that. This bill's just removing a redundancy that really isn't doing anything. Representative New Brindley.
Thank you, Madam Chair. Perhaps we can get clarification from nonpartisan staff, because while you're right that it doesn't state in the negative that they cannot diagnose, it does state in the affirmative that they may only provide ongoing psychiatric care, which implies the negative, that then they can't do the initial care and treatment plan. So while it doesn't give the negative, in the affirmative, it says they are only allowed to do this. And it uses the word only. So I'm wondering if we can get clarification.
Sunderman?
Madam Chair, members, I think it's important to look at subdivision 1 of this section as well. This is it's physician assistants shall practice medicine only under an established practice agreement, and the scope of practice includes services within the training and experience of the physician assistant. So this has to be in place regardless. Subdivision 5 is essentially an additional collaborative practice agreement that if a PA wants to provide ongoing psychiatric care to children with emotional disturbance or adults with serious mental illness, they have to have this extra collaborative practice agreement. And this section, or this subdivision, is more specific as to what that must include. But repealing this does not get rid of the initial practice agreement requirement that requires the PA to practice within their training and experience, if that makes sense.
And I would just say, Representative Brindley, I think that kind of proves your point that this is confusing.
Well, and can
Representative
I ask one more clarification? Thank you, Madam Chair, because actually that was helpful. So Ms. Sunderland, are you suggesting then that because of subdivision 1, the requirement would actually be in place that physician assistant would have the additional psychiatric training to be able to practice at that level?
Ms. Sunderman?
Madam Chair, members, I would say that currently the practice agreement requires the PA to only provide services within their training and experience. I don't know how it is working out in the real world, what a practice agreement might include, if it's broad, if it's very specific. So I can't really speak to the individual practice agreements, but under the statute, it should only be services within the training and experience of the physician assistant.
Madam Chair.
Representative
And
Brindley?
that might include, that might include ongoing psychiatric care, but not necessarily.
Thank you, Madam Chair. And thank you, Ms. Sunderland. Actually, that is really interesting to me, because perhaps that would give hopefully everyone maybe some comfort with this language, removing subdivision 5, but clarifying that as part of the agreement, that PAs would need the additional training and education to be able to practice at that level, so that we know that if those PAs are functioning at that level, that they would have that additional education and training. That might be the answer to ensuring, it's likely already the case, it sounds like, but to ensure that it's happening in practice. Thank you, Madam Chair.
Yeah, thank you, Representative Brindley. And I think, as I said, across many different areas of health licensees, we see the same kind of issue. it's very hard to spell out everything that's within the scope and outside the scope. And as has been pointed out, the APRNs don't even have a practice agreement. They got rid of their collaborative agreement. They themselves decide what their scope is without a physician at all. So, it's kind of I guess, something that could be looked at across all of our practice acts. But it's not what's before us today is the issue that, in my view, and the reason I included this in the bill, is that taking out this section only resolves confusion. It doesn't increase anybody's scope. And so, it's not because they have to be under a practice agreement. And, if you want to work, I think for next year, go ahead and work on better definitions across the board. But I have to say, PAs also practice in other areas, just like APRNs do. I mean, it's not just mental illness, it's across lots of very important areas where, just like physicians, what they do matters a great deal to people's health. So, we could say the same thing about, I don't know, I'm struggling to pull up some area of medical practice, but, they follow people and, do work in lots of critical areas, not just this one. So, yeah, Mr. Lehman?
Well, just two comments, and I know this is taking more time than you probably expected. One is, Madam Chair and Representative Brindley, subdivision 5, you also look at the word ongoing. That is not defined. So again, clinicians in hospitals are saying, if a patient presents in the ER and a PA sees them, does that mean they're barred from seeing them when they're admitted upstairs? If a PA sees a patient in a hospital psych unit, are they barred from seeing that patient once they're discharged? What is ongoing? No one knows. The other thing I'll just repeat again, the Board of Medical Practice, who's charged with protecting the public health and safety, supports this provision, supports this bill, and as they say, they voted at its January 13th meeting in support of this. If the concerns that are being raised about PA's quality or education or practice were real and valid, here's who would be issuing sanctions. Here's who would be investigating those complaints. Here are the people who would be taking action to protect the public health from these things that are happening. The reality is they aren't happening. There aren't complaints being filed with the Board of Medical Practice. Patients are not being harmed. PAs are not sort of willy-nilly going out and just doing stuff. That violates their training, it violates their license to practice, and it violates their sort of ethical code to do what they can do, but when they can't, just like an APRN, just like perhaps an internist may have to refer at times. Patients may come to an internist and they may say, this is beyond my capacity. Clinicians have to refer on to someone, and that's what PAs do. They practice within their scope and within the guidelines. And again, and the final comment I'll make is PAs evolve in their education. A PA may start out of school and have a very limited scope agreement with their physician. As they get more experience, that scope may expand as their physician sees that they're better. An anecdote, Dr. Trangle, who used to run the psych unit at Regents, years ago when we were having earlier conversations about PAs, said in a public meeting that Tracy Kaiser, who helped run the unit with him, who was a PA, was a better clinician than he was. This is a board-certified psychiatrist saying the PA was a better clinician than he was. So you need to look at the individual PA and what their experience is, but it's sort of a blanket, no PAs have this training, no PAs have these skills, patients are at risk.
Mr.
Just
Lehman, we
doesn't
need to
merit.
cut this off
Yes,
and move
I appreciate
on.
that. Thank you.
And Ms. Abderholden, is there something new that needs to be said? Please.
Yes, Madam Chair. The only other thing I wanted to mention is that when we found the form that originally had been agreed to by the Board of Medical Practice about what that collaborative agreement looks like, it's a series of check boxes. And treating serious mental illnesses is not on the list, and prescribing antipsychotics is not on the list. And so those agreements don't really protect people with serious mental illnesses. Thank you.
Well, I don't know that there's anything that says that that's the form that people use and that's what the collaborative agreement has to look like. I'm not aware of that, but okay. We're going to move on. Thank you both.
Thank you.
And the one thing perhaps left with this is, Mr. Harney, did you want to say anything about the spreadsheet for this at this point?
Madam Chair, members, not necessarily. If members have questions, I'm happy to clarify. The top half of the spreadsheet articulates the expenditures and appropriations made in Article 9. The second half of the spreadsheet shows the corresponding fee revenue into the state government special revenue fund. Big picture net impact to that fund is $138,000 in fiscal years 24 and 25, and a savings of $29,000 in the Dales.
Okay, thank you. So any questions about that, members? Okay, so the bill as amended is laid over, laid over, and we'll take it up again tomorrow.